My name is David Bernier, and I'm one of the Planning Committee members, and you're here for the federal and state approaches to integrating care for Medicare-Medicaid beneficiaries. Elizabeth Gattine is the speaker. Elizabeth is a senior policy associate in the disability and aging area at the Muskie School of Public Service. The Muskie School is part of the Cutler Institute for Health and Social Policy at the University of Southern Maine. Prior to joining the Muskie School, Elizabeth spent almost 20 years in state government, all of them in aging and disability service area. Elizabeth worked at the state's legal services developer, a position that is required under the Older Americans Act to help ensure adequate access to legal advocacy services for elders. She also served as the program manager, acting Maine's long-term services and support system servicing elders and adults with physical disabilities. She's a graduate of Dartmouth College and received her law degree from Columbia University School of Law in New York City. I'd like to welcome Elizabeth. Thank you.
Thank you so much. As David said, my name is Elizabeth Gattine, and I'm here to talk about sort of a healthcare policy track on what are often called the duals, the dual eligibles. But before I get started on that, I just really want to say thank you all for coming to this conference. And as was said, I spent 20 years working for the Maine Department of Health and Human Services, all of those years within the aging and disability service areas. So I have participated many times in this conference myself. I just have always loved this conference. I've helped with some of the workshops in the past, so I am just really pleased to be here, and I understand how busy people are. I also understand that the only thing between you and lunch is me, and I'm looking out there at the beautiful scene and the beautiful day. So rest assured, and I know Marilyn will also ensure, that we will have you out with plenty of time to spare. I'm also here for the conference, and the Muskie School also has an exhibition exhibit booth, so feel free to drop by if for some reason you don't get a question answered today or have some interest. Come look me up. I will be glad to talk to you. So we might as well get started. So I have some fairly simple goals for our time together here, and it's really to tell you a little bit about who are the duals, what we mean when we talk about duals, why are they of such interest, and they really, a lot of focus right now is being paid on dual eligible individuals at the federal and state levels. So why is that, and what are some of the federal and state approaches being taken to improve the experience, improve the quality of care, and the beneficiary experience in receiving that care. So basically, what I'm going to try to do, this topic can get very confusing very quickly. Anytime you talk about Medicare and Medicaid, it's hard enough to talk about one of those programs without talking about both of them. I'm going to try to sort of, I've tried to provide a level of detail, but also I will try to keep it to, you know, sort of these takeaway points that provide a foundation for everybody. Because one thing I also, I guess, want to say at the outset, and I really recognize this and mean this, is that this is a great conference in part because it draws so many different people from so many different aspects of professional and personal interests that bring you here. So many people touch these systems in different ways, have a lot of experience that they bring to bear. And so what I've tried to do is say, okay, I'm going to try to create a common understanding among us all that we can build off of, still provide some detail, but also try to provide a basic foundation for folks who maybe are not as familiar with some of the healthcare policy issues that I'll be talking about today. So the takeaway here is I'm going to be talking about who, why, and what. And maybe we can treat it to make it a little bit exciting, a little bit like a detective thing. Why don't we try to investigate, look for the clues about why there is so much attention right now being paid. So let's talk about duals. That is not the kind of dual we will be talking about today. Okay, that's the DUEL. We will be talking about the DUAL. And I also want to stop right here and tell you how hard it is to come up with jokes in the healthcare policy arena, okay? So I at least get credit for trying, okay? It is very hard. So what do we mean by duals? Well, it's very simple. We mean that they are individuals, often called beneficiaries, who are eligible for both Medicare and Medicaid at the same time. The more formal designation, the way you see this written a lot or referred to a lot, are Medicare-Medicaid beneficiaries. They have sort of adopted the nickname of duals, and you do hear the word duals a lot, or dual eligibles. And that's what this is referring to, people who are eligible for Medicare and Medicaid. So, fun for you guys. I find it fascinating. Let's see if you do. But it is hard to talk about duals without at least talking about some basics about Medicare and Medicaid. Obviously, these are very complicated programs. They have a lot of implications and aspects to them, many of which is beyond the discussion we're going to have today, but at least I think I need to cover some of the basics that really are directly relevant to the dual population. Interestingly enough, or not interesting, I mean, I find it fascinating, I don't know. Medicaid and Medicare are both 50 years old at this point. I think they're actually 51. They turned 50 last year. I don't know if anybody gave them a party, but there was a lot of very interesting retrospective about the programs. And sort of how they've developed in the last 50 years. And when they were initially passed in 1965, Medicare was the larger of the two programs. Medicaid was, I don't want to call it an add-on, but it was a much smaller initiative. Medicare was the program that, at the time, people really thought was going to be the program that was going to continue to expand to include other populations, such as children and other populations, Medicare for all, sort of in that direction. But as you can sort of see by this next slide, depending on whether you look at the spending or the beneficiaries, depends upon which program is bigger. So actually, you can see that in terms of the number of beneficiaries served, Medicaid now is actually the larger of the two programs. In terms of spending, Medicare continues to be the larger spending. I think it's fair to say, and you can see the expenditures on 2014, over $600 billion for Medicare, almost $500 billion for Medicaid. I think your take away from this slide is they are two very large programs. And over time, I should say, and we'll talk a little bit about this because it's relevant to some of the other parts, but Medicare has expanded over time to other population groups, primarily people, younger adults, 18 to 64 with a disability, as well as individuals of any age with end-stage renal disease. So it's not that there hasn't been as much expansion. That, I think, happened back in the 70s. But Medicaid has been the program that has continued to expand a little bit more, and the vehicle for covering additional populations. So again, this slide, you know, there are people who love numbers, and there are people who are like, no. So again, I wanted to include some data, and I'm assuming, Marilyn, will these slides be available after the?
Thank you. They're posted on the website already.
Okay, wonderful. So I like to include more information probably than I need to in some of these slides because maybe somebody later in time wants to use them as a reference or go back and look at something a little more closely. So this just shows, if you look at the two browns, actually it comes up very close. That's good to know on these slides for future. It's very little difference, but the sort of one of the yellows and the brown there, this just shows from 1970 to 2040, the growth of Medicare and Medicaid in terms of the federal budget. And really the very simple takeaway point here is it's gotten bigger and it will get bigger. And will continue to be a major expense of the federal budget, in part due to the aging of the population nationally, and obviously we hear a lot about that in Maine, but that is certainly one of the factors. And obviously a lot can impact what happens before we get to 2040, but that's just based on the projections and the information that we have today. So, as I said, it's just really, your takeaway point is big programs. So the next slide, whoops, I almost made the screen dark. One of these buttons makes the screen dark, I was told, so I almost went for that one. So in any event, again, I don't want to get too deep, but there are some operational differences that are very important when you look at the dual eligible population and strategies for improving care to people who are dual eligibles. And a lot of this information, I'm sure to people in this room, is already familiar and known. It's just a good reminder that, again, Medicare is a national program, and it is administered by the Centers for Medicare and Medicaid, CMS. You'll hear me refer to them several times during this presentation. Whereas on the Medicaid side, it's really a joint program with CMS and the states. There is oversight by CMS, but it is driven a great deal on the Medicaid side by state policy and profile of the state. And one of the other little things we like to say as state policy folk is that if you have seen, and many of you have probably heard this, but if you have seen one state Medicaid program, you have seen one state Medicaid program. And they tend to have a lot of flexibility and look very different. And even if you look across the New England states, and look at the state Medicaid programs, they look very different. Maine looks very different from Vermont, from Massachusetts. Rhode Island is very unique. Rhode Island has an 1115A global waiver. Some of you maybe have heard that term. So on the Medicaid side, things can look very different. They cover different eligibility, they have different benefit packages. Whereas the Medicare is a much more uniform program administered through CMS consistently across the country. So again, Medicare has uniform eligibility and benefits, and Medicaid will look very differently state to state. The reimbursement methodology and rates for Medicare are set nationally. They maybe recognize a geographic distinction within a state, but still the methodology is uniform and nationally. Whereas on the Medicaid side, reimbursement methodologies and rates are set at the state level. There is, again, some federal guidance about what may be required around it, but there is still a lot of authority within the state. And the funding becomes very important when you look at strategies for approaching improving care to duals. The funding of the two programs is very different. And Medicare is funded primarily through payroll taxes, premiums, and some general revenue for some parts of it. But the Medicaid does have a state cost share. It's called the FMAP, and that is the difference between, a match for a state dollar versus the federal dollar. That FMAP, again, varies across states. There's a formula for determining that, but states have state general fund dollars invested into the Medicaid program. And I should say, and I'm sure all of you are aware of this, but just to be super sure, Medicaid in Maine is called Maine Care. And again, similar, as I said, that the fact that states have a lot of control over their Medicaid programs, many states have developed their own unique branding of their Medicaid program. So in Massachusetts, it's Mass Health. You see a lot of states sort of identifying in their own way how they would like to see their Medicaid programs referred to. And in Maine, that's what we call Maine Care. And I should say in Medicare too, and I'm sure you're all aware of this, but I'd just like to be sure, Medicare has sort of the 4 parts. It's got the Medicare Part A, which is the hospital benefit, Part B, which are the physician services generally, I'm sort of generalizing. Part C are the Medicare Advantage plans, and I'm going to come back to those in a bit because that is one of the instruments or the funding mechanisms that are being used to really try to better integrate care for dual eligible individuals. And then Part D, which was added in the early 2000s, which is the prescription drug benefit. So, the other piece, and then we'll get to the exciting stuff, I promise. See, this is the problem with being a policy person. It's like, oh my God. But this is fascinating in its own way, as I like to tell people. Maybe that's a poor reflection on me, but I don't know. But it can be, it's a very interesting way. But I do at least want to mention the reimbursement methodologies. And I have to do that again because it's important. Oh, geez, I keep doing that to you guys. It's important when you look at the strategies for duals. So there are 2 principal types and ways of reimbursing for these services for both Medicare and Medicaid. One is fee-for-service, and that, for example, in your Medicare world, that's your Part A and your Part B. Those are traditional fee-for-service, and it basically means that a provider is paid for the service they perform. So if there's a lab test, you're paid for that lab test. If there's an office visit, you're paid for that office visit. It is a fee-for-service. It is based primarily on volume, and so that's why you're seeing a lot of move away from fee-for-service, or at least a modification of fee-for-service to include some sort of performance-based or initiative-based payments to look beyond just the you provide a service, you get the fee, but to try to look beyond that to what are the outcomes that are being achieved by that service, and trying to drive some incentives around looking at the outcome as well as just the delivery of that particular unit of service for a particular fee. But there is still a lot of fee-for-service. And then there is managed care, which is available, which you see in both Medicare and Medicaid. And that is where the health program, the Medicare or the Medicaid, contracts with a health plan to provide a set of covered benefit to a certain eligible population for a fixed amount per beneficiary, and that's often called the capitated rate. It's often a per member per month, and these are often risk-based. So the plan will get a per member per month fee, and they will have to provide the services that are agreed upon to that eligible individual, and they are at risk. If it costs more or less, they are at the risk for that. So they have an incentive to try to provide efficient and effective delivery of service. So Medicare managed care is, as I said, your Part C. Your Part C Medicare Advantage plans. And people can receive their Part A and their Part B services through that plan if it's available in the geographic area. And there may be some differences, but basically they're required to provide the services in Part A and Part B, and they assume the financial risk again. And what we're going to be talking about in terms of the Part C are some of the special needs plans. And so I'll save that discussion for later. But there are certain subset of the Part C Medicare Advantage plans that are called special needs plans. And I'll come to that in a moment because they have played a pretty significant role in trying to create innovative ways to better manage care for people who are dual eligibles. And Medicaid managed care, I'm not here to really talk about that, but I think it's interesting. Let me say that a lot. It's interesting. You'll say, what does she do all day that she finds this stuff interesting? But it is a trend that you will see nationally. I think last time I looked, there were just slightly over 10 states that had no managed care in their Medicaid programs, Maine being one of those states. So you can see the trend towards managed care nationally in Medicaid has been something of enormous growth in the last decade. It does not mean that all of the states outside of those 11 have everything in managed care. In fact, some of them have very few folks in their Medicaid programs in managed care. Some have everybody in their managed care. But it's going to be a consistent theme here. It goes back to the state design. And what are the state policy drivers? What are their strategies? What are they trying to accomplish? So some states, for example, have carved out certain populations. They've carved out people with behavioral health, or they've carved out the dual eligibles from participation in managed care. Some have carved out certain services, and a common example of that is the long-term services and supports, which is of a special interest to me, because I was program manager for many years in Maine for elders and adults with physical disabilities managing the long-term care program. So I will say up front that you often hear it and see it as LTSS is a particular interest and passion of mine. But some states have carved that out partly because of the difficulty of integrating those services within the acute and primary care models. So the Medicaid managed care continues to grow. I think we will see more of it. That would be a whole nother discussion, but I think that it is an important trend to note as we go through here. Because it will, again, affect a state's decision as to how they want to approach initiatives for improving care. Okay, so now I'm going to switch gears a little bit and talk about who are these duals. I mean, I'm talking about Medicare, Medicaid, improving this, improving that. Those were the big programs and what the big programs that they're accessible at. Now I'm going to try to narrow this a little bit into looking at the duals themselves and try to figure out, who are they and why are people paying so much attention. So, again, as I said, they are people who have eligibility for Medicare and Medicaid. I only want to mention, in case you have an interest in this and you want to look at it or you're looking at other information, you may see the term partial and full dual. So there are two types of duals. Some are full duals, and that means that they have Medicare, but they also have full eligibility for Medicaid. There's another group of people who are eligible for Medicare, but the only benefit that they can get from Medicaid is help paying some of their cost sharing for Medicare. And some of you may know those programs as the QIMBY, the SLIMBY, those lovely acronyms. Don't ask me to tell you what they stand for. I used to know, but I just refer to them as the QIMBY SLIMBYs. But that is really the Medicare savings programs that I think a lot of you may be familiar with. So that's what creates a partial dual. They just have a limited benefit under Medicaid, but they are technically under both programs. So there is a interesting relationship between Medicare and Medicaid when somebody is on both programs. Medicaid is the payer of last resort, meaning that if the service can be covered under Medicare, Medicare pays first, and Medicaid only pays for those services that Medicare will not pay for. I hope I said that right, but I think I did. And so if somebody does not have Medicare, it doesn't mean that they can't get some of those services listed on this slide under Medicare. It just means Medicaid would pick that up for them too. But for those people who have access to both, generally speaking, at a sort of a high level, you're going to see that the Medicare picks up the primary and acute services, prescription drugs, skilled rehab, and specialists, those physicians, inpatient hospital, and Medicaid generally covers the long-term services and supports. And that can include institutional long-term care, such as a nursing facility, and it can also include many of the in-home services people receive, such as personal care, private duty nursing, some of the waivers that you may have heard about that also include things like home modifications and other home and community-based benefits. And then again, Medicaid for these individuals can pick up the cost of the Medicare premiums and cost shares. So the dual eligibles sort of receive different services from these programs slightly differently. And again, the Medicaid benefit can vary pretty significantly between states in terms of what is available on the Medicaid side. So, the numbers of duals. Looking at this, you can see that there are about, in 2011 data, there were about 50 million people on Medicare, and on Medicaid, there were about 60, and the crossover of that is about 10 million for the dual eligibles. And I want to stop here just for 2 seconds, maybe 1, maybe 3, and just tell you about the data sources that I used, because it is a point to be in this world of healthcare policy, you must have patience. So what I decided to do, will not surprise anybody that you'll see different numbers for a lot of this information if you go to different websites, and there is a lot of information out there. And often it's because people count things differently. Is it the average monthly user? Is it the total users over the year? When they look at the revenue, does it include the cost shares? Does it not include? So what I try to do when I do a presentation is at least be consistent in my presentation of the data and use the same source so that we're sort of looking at apples to apples and not start mixing, 2011 with 2014 and moving things around in different ways and methodology of collecting data. So what I used, look. The service here is incredible. Okay, look at this. So what I used, and it just demonstrates the patience you have to have. I used the 2016, okay, note the year, the 2016 data book that's put out by MACPAC and MedPAC. And those are two organizations that have authority to basically report to Congress on the Medicare and the Medicaid programs. And the 2016 data book relies on 2011 data. And that just shows you the lag it takes to get the data in place for these two huge programs. And so you're seeing 2011, but I can tell you that that is current data, at least a current source of data. And it just takes a lot to get the data together. There are some more current forms if you look at them, but it's hard to get, again, the consistency across. So I just wanted to explain why you're seeing 2011 data. I also had my phone somewhere for time, but I'll wing it. Okay, so this shows you the numbers in Maine. And again, some people love numbers, some people don't. I would try to focus on the percent. So 1, 2, 3, the fourth column over. So these are looking at the number of duals nationally and in Maine. And as compared to the general population. So I guess the takeaway for this would be nationally, 16% of the population is on Medicare, and in Maine, 22% of the population is on Medicare, so a little over the national average for people on Medicare. Same with Medicaid. Nationally, that number is 22% of the population is on Medicaid. In Maine, it's 33%. And as a total population, it's 3% of the duals, 3% of the general population are duals, 8% in Maine. So my only point here is it's of relevance to Maine, and we ought to be looking at it because, in part because of our aging population and other aspects, we certainly have an interest in looking at these. And then again, that just says 20% nationally of Medicare beneficiaries are duals. In Maine, it's 36%. And again, nationally, 15% of Medicaid beneficiaries are duals, and in Maine, it's 23%. So it's a little higher, as you can see, not insignificantly higher in Maine for both Medicare and Medicaid and the numbers of duals. So, stopping there for a minute, that is certainly one clue. We can do a mystery tour. I'm finally at the mystery tour. I'm finally at the clue. So one clue are the numbers of duals that we have. That's one thing that causes policymakers to look at the duals. There's a significant number. Is it everybody on Medicare or Medicaid? No. Is it more than half? No. But is it significant? Yes. So let's see what else may be of interest to policymakers. And where policymakers tend to go next after the numbers is the costs. So again, I would just stick to the main column. I put in the others for information later if anybody's interested. But almost $300 billion in costs for the duals. And the breakdown is between Medicaid is the lighter yellow, Medicare. So Medicare is still picking up the greater percent of the costs for duals, but it's significant for both programs. So costs, factor. The next slide leads another more insight. Something that really grabs policymakers' attention is looking at the spending. So this can be a little complicated, but if you just look at the one on the left, that's Medicare. The other one is Medicaid, and if you can just focus your eyes on the brickish color at the bottom, what this is telling you is that 20% of beneficiaries utilize 35% of the expenditures on Medicare, and on the Medicaid side, 14% of the beneficiaries utilize 33% of the expenditures. So that is what one might call a disproportionate spend. So smaller numbers of people using higher or utilizing a higher number of services. So that's something that is always going to catch a policymaker's eye, because people are going to want to understand why is that happening. What is it about that population that is causing that? I'm still trying to find my phone because I do not. Thank you. Oh, see? Oh, it takes a village. Okay, I'm doing fine. So that's always going to be one of the reasons why people will look at this. So now the next question will be, I know this is busy, do not worry. I will not test you on any of this. Now the question will be, okay, we've seen significant number of people, a lot of money, just generally, and it's a disproportionate spend. The next natural question would be, why? So that's what people are going to want to know. Why is this happening? So this is just the demographic profile that's very busy. I hesitated about including the whole thing. I decided to for just reference purposes later. It really breaks it down by age, by full benefit, partial benefit. But if you look at, and I did highlight the wrong column, but that's okay. I'm still scared which one of these turns the screen dark, so I'm not going for it. But if you could look at the first column that's in white, and then don't look at the last column that's in white, but look at the one right before it, and the numbers may be too small. But basically, if you want to look at the profile of the duals, they're predominantly female. So I'm looking at the first column. 61% are female. 57% are white. And you see a much larger Hispanic, African-American makeup to people who are duals than non-duals. And then the urban-rural doesn't change too much between the two. But what does change is really the race ethnicity, as well as a greater percent. It's 53% male, 47% female of the non. Oh wait, I'm looking at the wrong column. 47, 53. It's closer to half and half, but once you get to the duals, the female much higher percent. The other one that's interesting, and this one you can really get lost in, but some may just love it. I just want to point out a couple things. So these are the other characteristics. And when you really look at it, some of it is very, very startling. So the first one is limitations in ADLs. And the highlighted columns are correct, but the numbers are almost a little off. But 32% of duals have 3 to 6 ADL limitations versus 9% in non-dual. So 1/3 of the dual population has between 3 and 6 ADL limitations or ADL needs. And those are activities of daily living, bathing, dressing, transfer locomotion, as opposed to 9%. And when you look at the reported health status, you also see big differences in how people report their health. 17% of people who are duals report poor health, whereas that's 6% for the non-dual population. And the education is also striking. 17% of the non-duals have no high school diploma. That number rises to 48% when you get to the duals. So there are many, many, many things you can read. Many reports on sort of the profiles of duals, and you can look at like the emergency room usage, there was so much information. I think that really what I just wanted to bring out is that they tend to be, as a generalization, a sicker population with more chronic diseases, income, education, some differences there from people. The only other thing I guess I will point out on this is the institution. So under living arrangement too, which is part of the expense of the duals, is 21% reside in a nursing home, nursing facility, and 5% of the non-duals. So that's also a big difference when you look at the profile of the duals. So, and I just wanted to point out this, it's on the, do I bring my glasses up and down a lot? I think this is the time I need those transitions. If I can find time to get to the optometrist, that would be great. There is a chart book that the Muskie School did a few years ago that looked at Maine Care, Medicaid, and Medicare expenditures and utilization that is of interest. So I took this next one. So we were just looking at the Medicare profile of duals. I'm switching for a minute to the Medicaid profile and the Medicaid profile in Maine. And this data goes back to 2010, which isn't consistent with the other data, but I thought it was just interesting to look at. This is prevalence of selected chronic diseases among older adults and adults with disabilities. And you can see, looking at the dual eligible on the one side, things like depression, heart disease, dementia, COPD, arthritis, chronic heart failure, stroke, those are all higher amongst the dual population. I do not have the spending data for the duals in 2011. The MedPAC-MACPAC book didn't give that by state, and I felt one of the issues, some of you, I'm sure some of you lived this with me, I was at the state then. 2011 is the year that the Department of Health and Human Services changed over to their new claims system. It was right around that time, and not unusually and to be expected, some of the expenditure data gets a little wacky during that time frame as the claims data switches over. So there were a lot of caveats on all the data, and I just decided not to use the expenditure data in Maine, but there's no reason to think that it wouldn't be similar to the trends and what we're seeing everywhere else. The other point I want to make before I move on is even though we've looked a little bit at the profile of the duals, one of the things that is really important to understand is that even within certain subgroups of the duals, their needs vary a lot. So it's not as if you can look at one group. I mean, I haven't even really looked at the behavioral health needs of a lot of the duals. So even within the groups of duals, and that's why the breakdown of the ages is interesting if you want to get to that level. The younger duals have a slightly different profile than older duals, and so even within the duals, it's not as if you can just come up with this one-size-fits-all, oh, here's what we need to do, and sort of overlay it onto the population, because there are some very different, diverse needs. So, we've answered some of the questions. Who are the duals? Why people are interested, and we said some of that's the numbers, some of that's the spending. We've also answered a little bit, why is the spending looking like that? And that's because they generally have high needs. But there's another piece that really, to me, again, personally, makes them somewhat alluring to look at. Can I use the word alluring in this sense? But it's very alluring to me. And really beyond the numbers, it is the fact that historically, duals have received these services through separate programs. And Medicare and Medicaid traditionally have been somewhat siloed, separate programs. And I mean, I worked at the state on the Medicaid side for 20 years. And you know, for a lot of that time, the most I was interested in is, should this claim have been paid by Medicare first? And, you know, it was through the claim reimbursement side of things. It wasn't on the beneficiary side, which is where we should all be focused. It was really back on the financing, you know, are we being sure that the right program is paying for the right claim. And I think where we need to move our attention now is to the beneficiary, and that's what's happening. And how can we improve the outcome for the beneficiary? So, but traditionally they have been separate programs, and they still are. And so there's limited control, and I know, again, speaking from personal experience, when somebody called me with a problem about Medicare, and they didn't like a Medicare policy, I would say to them, well, I work with the Medicaid program. You really need to contact Medicare. So there, you know, there isn't a lot of cross authority around some of these issues. I don't have authority on the Medicaid side over the Medicare and vice versa, although there were some linkages here and there. So what does this result in? Well, I think we've all recognized that it results in barriers to coordinated care. It can result in very fragmented care for the beneficiary. It can be very difficult, and I'm sure there are people here who have helped beneficiaries navigate particularly the transitions of care as somebody's going from the hospital under Medicare and they're going to skilled care, but then they may need long-term care. Those transitions and the navigation between those payment systems is less than ideal, I guess is how I would say it. So the two programs and the way they're set up leads to that fragmentation of care. And there's also a lack of financial alignment between the two programs. And when I say that, what I mean is, and this is a very important point from a policy perspective, there is the potential for cost shifting. So that's one thing. Home health is covered under both. Which way are you going to do it? The SNF to the NIF, the skilled nursing facility to the nursing home, which program is going to pick up what. And then there is a lack of incentive, because often where the savings will come is on the Medicare side. So if you put a lot of money into the Medicaid, and maybe with home, community behavioral health or other services that maybe reduce hospitalizations on the other, Medicaid spending the money, Medicare is getting the benefit. So I'm going to move up because I should have had my phone earlier, but I'll still get there. So one of the huge changes that's happened in the last couple of years is CMS has really recognized this, and they've created two new offices. The Medicare-Medicaid Coordination Office that is specifically geared to aligning these programs, and the CMS Innovation Center, which doesn't only deal with the duals, but a much larger crowd of innovation. So the two strategies that states are using and the federal government are to better coordinate care and to integrate the financing of the care to stop that cost shifting and the lack of incentives that appear. So they can be either under the fee-for-service system or a managed care system, and they can be Medicare incentives, Medicaid, or both. So I'm going to talk about a couple of examples in Maine, very briefly at a high level and nationally, and I've just noted on the slides which ones exist in Maine, and also the difference here is this is really a continuum. Which ones are targeted specifically for duals, and which ones are general initiatives that duals can get some advantages of because they also have complex medical needs, and the initiative is a larger one around folks with complex medical needs. So multi-payer models is one. Maine has a demonstration going right now, and that's basically where Medicare, Medicaid, and private insurances make a payment to practices to really enhance some of the support, the care management functions. This is not targeted at duals, and one of the things this one does not do, and a lot of these first ones, they don't have anything to do with the integration of the finances between Medicare and Medicaid. Health homes, very similar. It's a Medicaid option. And again, it doesn't directly target duals, but duals could benefit from some of these. And it's basically aimed at, again, more enhanced care coordination. ACOs, very similar. There are Medicare ACOs and Medicaid ACOs. I mean, they're different structures, but in terms of what we're talking about what they could accomplish for duals, it's really an enhancement, but again, it doesn't go to the finances. Medicare uses the Part C, their Medicare Advantage plans. They have special needs plans which recognize the unique characteristics of populations. So they have something called the D-SNP, which are dual. That's what the D stands for. And so basically, they can vary dramatically between the level of integration. Again, it's the plan and the state decide the level of integration between, it's a Medicare managed care plan, and so that plan will work with the state to determine the level of integration. Some of it is very minimal, some of it is quite coordinated in terms of helping provide and may even provide some wraparound Medicaid services. The next layer down from that is something called the FIDE-SNPs. Next joke, get ready for it. Not to be confused with the FIDO-SNAP, which is the biscuit you give your dog. But the FIDE-SNP is a fully integrated, dual-eligible special needs plan. It takes that integration of the Medicare managed care plan to another level. And it's only available in a couple states. I think 7 states have them, because the state has to have a managed care LTSS, long-term services and supports program. And I will be willingly deal in any detail anybody wants on these, but I also don't want to drown you in it. I only have 2 more to go, so I think I'll be on schedule, but and could probably take a question or 2, and again, I'm around for that. The other one that might be interesting, and you may have heard a little bit, because it's been knocked around as an idea for a while, even in Maine as well, and that's PACE, and Maine does not have a PACE program. It's a program for all-inclusive care for the elderly. It is a very integrated model of care. It is basically a complete integration of your Medicare and your Medicaid together, and it becomes the sole source of payment. It's built around really an adult day model. And it's really, I've toured a couple of these centers. They're really interesting. The profile of the PACE is on this slide. The average PACE participant is 76. They are, again, when you look at that, participants have an average of almost 8 medical conditions. 47% on average have dementia, and the next bullet is the one that's really impressive. More than 90% of these participants live in the community, and that's what PACE has been able to achieve for people. It's a very integrated setting, and so you say, oh, well, why hasn't PACE taken care of this? Because it's been around for quite a while. It's in 32 states, but it's the second bullet that should catch your eye. Nationally, only 35,000 people are in PACE participants, and there are lots of reasons why. There are some very natural or regulatory, I should say, restrictions for why PACE, though it is a very integrated and successful program, generally, why it's been able to serve so few people. And a lot of it is because it requires a bricks and mortar structure, a lot of investment. It does revolve around an adult day. Many people have to give up their primary care in order to join the PACE program. A lot of people are very resistant to that. But to address some of these, it also is limited to 55 and older, and you have to have nursing facility level of care right now. So the interesting thing here is in November of last year, Congress passed the PACE Innovation Act, which is going to encourage demonstrations of states to look at serving perhaps younger populations, populations that meet a different eligibility, and it's a way of trying to broaden what I think most people would agree is a good model, but has some restrictions that just doesn't serve a lot of people. I will point out in Maine, the Department of Health and Human Services in February of this year did issue a request for information. It's not a request for bid, but they are interested in exploring this option, and I included the RFI number for anybody who wants to look at that. I know it was under discussion when I was there. Now, the last thing I'm going to talk about are the financial alignment demonstrations. And they're really fairly in their infancy in the world of when you look at the data. But these are ones that are, again, truly integrated models, similar to PACE, but trying to expand it further. So there are 10 states that are testing a capitated model, meaning a managed care model. 2 states working with a fee-for-service, Washington State being one of those that is using its health home model to really try to expand to duals. And really, the fee-for-service, how it differs from some of the other ones is there's allowed cost sharing with the Medicare savings. So usually, again, on if you have a Medicaid incentive, people don't, the Medicaid program doesn't have the incentive to create savings on the Medicare. The managed fee-for-service allows the cost savings to work in a way that does encourage, regardless of the Medicare or Medicaid side, to try to do that. And the capitated also do the same thing. It's an integrated payment, so it's really quite fascinating. I know I use that word a lot, but it's integrated financing. of Medicare and Medicaid, the individual, the beneficiary, has one eligibility card. They don't have their Medicare card and their Medicaid card and their prescription drug. They have one card, one enrollment, integrated appeals, one set of benefits. It's been very helpful, or it's been very interesting to see that. They're 3-year demonstrations, but CMS has offered to extend them by 2 years. So you can see they're still fairly recent in the world of, sort of trying to manage and look at the, whether they're successful and what are the results. Washington State went live in 2013, which is a fee-for-service, managed fee-for-service in Massachusetts in October of 2013. So I've included in here some of the findings, and I have resources at the end, but really, I'll just say this, I think, about the findings. Imagine 2 huge programs trying to merge administratively in a seamless way for the beneficiary. So there's one enrollment process. You don't do enrollment here and enrollment here. There's one enrollment process. Medicare enrollment systems have to come together with Medicaid. And for anybody who works with IT systems, and you have these huge systems and Medicare that works nationally, it has been an interesting, I think, experience. And I think the goal that everybody shares is to make it seamless for the beneficiary. Regardless of what's happening here, you want what's happening out there to be useful. So what they've done, another unique nature of it, is they've created joint management teams between CMS and the states, because usually it's the state managing Medicaid and CMS over here managing Medicare. This is a joint program, so CMS and Medicaid have come together in joint management, and that's been a very important piece. And my last piece that I always just like to look at is the LTSS, and that's really trying to integrate the LTSS and getting people to understand how to do that successfully has been some of the experiences of this. So there's also ombudsman, and there's a lot of stakeholder engagement in these, as you can imagine. But they are still relatively early, and I have my stay tuned, because I think we're going to have to stay tuned. I did put resources at the end, and I wanted to just point out that there are 2 reports that have been published from the financial alignment states that you might want to look at. One is on Washington State, and one is generally across the states. And maybe my last thing I'll say is that in New England, Massachusetts and Rhode Island are both part of the Financial Alignment Initiative. Those are the 2. Connecticut initially had signed up to be part of it, but decided ultimately not to proceed with that. So Rhode Island and Massachusetts are those. So we have about 1 minute, maybe less. I don't know, Marilyn, do you want me to take questions, or do you I'm always available. As you can see, I like to talk. Just come talk to me, and I shall answer.
And Elizabeth, I think because of the time, and I'm sure it's not going to be an easy question,
come find me.
Since you'll be around, will you be here tomorrow as well?
I will be here all day tomorrow.
Okay. So she's very approachable.
I am. Look at me. Am I approachable, guys? Come on, come on.
Whew. Let's give a round of applause.